Good afternoon and welcome. Looks like people are still joining, so we'll just give it another minute or two before we start. Good afternoon, everyone, and welcome to this National Bleeding Disorders Foundation Wednesday webinar. My name is Fiona Robinson, and I am your host today. Today, we have an exciting new feature. This webinar is the first of 4 in a special Research Journal Club series. This is a collaboration between the National Bleeding Disorders Foundation, or NBDF, and the Hemostasis and Thrombosis Research Society, or HTRS. We're super excited to host the first of these 4 journal clubs today, and we would like to extend a special welcome to the HTRS Connector Junior Faculty Network members joining us. The title of today's webinar is Breaking Barriers in Bleeding and Thrombotic Disorders in Women. This webinar is being recorded. The recording will be available shortly after it ends on the NBDF website, bleeding.org. We encourage you to ask any questions you may have today. You can ask your questions by using the Q&A feature at the bottom of your screen, and you can ask your question at any time during the webinar, and following our speakers' presentations, we will put your questions to them. Today, we are joined by 3 expert guests. We have Connie Montgomery, a lived experience expert and a global patient advocate in Pawleys Island, South Carolina. Dr. Bethany Samuelson-Bano, Associate Professor of Medicine at the Oregon Health and Science University, and Dr. Leslie Skeeth, Associate Professor of Hematology at the Cummings School of Medicine at the University of Calgary in Alberta, Canada. I'd like to thank Connie, Dr. Samuelson-Bano, and Dr. Skeeth for joining us today. And before they start, I will just ask Maria Santaella, Vice President of Research Strategy at NBDF, for a quick word of welcome to this special Research Journal Club.
Thank you, Fiona. So today's a great day. After a couple of years of trying to make this happen, we're finally here. HTRS has been and continues to be the perfect partner and earnest collaborator to NBDF. Together, we're committed to workforce development and promoting truly centered research. I want to welcome everyone viewing this webinar. And like Fiona said, I want to especially welcome Ms. Connie Montgomery, who's representing the lived experience and the community that we so proudly serve. Also, Dr. Samuelson-Bano and Dr. Skeeth, who will be representing their work and the incredible organization called Hemostasis and Thrombosis Research Society, which is dedicated to research, mentoring, and workforce development for physicians, investigators, and healthcare professionals who are interested in advancing care for people with hemostatic and thrombotic disorders. Please help me welcome the first presenter in this exciting series of 4 webinars showcasing HTRS research programs. They will present the research focus on an area that is near and dear to everyone's hearts, women, a focus of study that has been characterized as critical by many, as well as initiatives such as the State of the Science and the National Research Blueprint. Now, the Bleeding Disorders Research Collaborative. Connie, I will pass it on to you.
Hello, everyone. My name is Connie Lee Montgomery. Thank you so much for introducing me. I appreciate it, Maria. It is an honor to be here today on National Barriers Awareness Day as well. Today, I'm going to share a little bit of my experience being a living experienced expert with Factor VII deficiency, which is a bleeding disorder where my blood doesn't clot like other people's blood. It's very important today that we have discussions and talks like this so women and teen girls and people with the potential to menstruate are heard and seen and taken seriously when they share their symptoms. I lived for many years with symptoms that went unheard and undiagnosed and incorrectly diagnosed. It wasn't until my mid 30s after a car accident that I actually got properly diagnosed. So today, as you listen to these experts speaking along with myself, I hope that you will tune in and listen for the signs and symptoms that we need to pay closer attention to in the future, as well as learn to collaborate and work with all partners in healthcare, the healthcare practitioners, the researchers, and definitely the patients and the families. Thank you so much for this opportunity to be here today and to share with you. I'll speak with you a little later in the program.
Okay, let me share my slides here because I think I'm next up. And definitely want to thank HTRS and NBDF for recognizing the importance of capturing female patients' experiences and all of the different challenges that come with being a menstruating or pregnant individual. And just want to take a moment to acknowledge that I realize that women and girls might not fit everybody's identity who menstruates or can become pregnant. The title of my talk is really female-specific health events and bleeding disorders because I'm really going to focus on things that only happen in folks who are assigned female at birth, like menarche or the first period, pregnancy, and menopause. So we're going to kind of go through in a timeline through one individual's life, if you will, with a bleeding disorder, thinking about menarche and menstruation, pregnancy, and as I mentioned before, menopause. So what is menarche? Menarche is simply the first period that someone has over the course of their lives. And menstruation is a really important event that happens every month, more or less, for up to 40 years of a person's life. So it's something that we really need to make sure we're paying good attention to. It's important to know that 90% or more of individuals with certain bleeding disorders will have heavy menstrual bleeding. And certainly the vast majority overall of folks with bleeding disorders who menstruate will have heavy periods. So it is both something that's important to recognize and treat in somebody we know has a bleeding disorder. It's also a time at which a diagnosis often the first time at which a diagnosis can be made based on bleeding symptoms, because it may very well be the first big bleeding challenge in a person's life. So that's a common time when we find out somebody has von Willebrand disease or they're a symptomatic hemophilia carrier or something else. Why is heavy menstrual bleeding such a big problem? Well, we know it really impairs quality of life. It increases costs for the individual and broadly in terms of the healthcare system, missed work, missed school, lots and lots of impact from heavy periods. Also leads to complications like iron deficiency anemia or iron deficiency without anemia, which has its own set of symptoms like brain fog and fatigue and decreased exercise tolerance and even hair loss. So something we really want to be paying attention to in the care of our patients with bleeding disorders. So how do we make the diagnosis of heavy menstrual bleeding? There are a variety of ways to make the diagnosis. I think my favorite and the most commonly used is really basically excessive bleeding that interferes with physical, material, social, emotional quality of life. However, we do often have to, in research, have some specific criteria so we can distinguish between different degrees of blood loss, acknowledging that I have plenty of patients who have had heavy periods their whole lives and they've learned to cope. And so they may not say that it interferes with their quality of life, although often after we get them under control, they say, oh yes, it interfered more than I thought. So here are some kind of objective criteria, if you will. So any period lasting longer than 7 days is a sign of heavy menstrual bleeding. Average is about 2 to 7 days. Changing a pad or tampon more frequently than every 2 hours. Also, wearing a pad and a tampon together or some other pairing of protection is a sign or symptom as well. I also note that this doesn't really incorporate the use of a menstrual cup, and that's because that wasn't incorporated in our initial studies where we started to make these diagnoses. But as I'll show on a lower slide or on a later slide, menstrual cups hold a lot of blood. And so really, if you're filling more than 3 or 4 menstrual cups over the course of a cycle, that's probably heavy periods as well. In terms of volume, flooding episodes, which every patient who's had one can tell you what that's like, but basically kind of a gush of blood. It often happens when somebody stands up. Clots greater than 1 inch in diameter or the size of a quarter, and then iron deficiency. So if you have any of these are a sign that you may be having heavy menstrual bleeding. So, how do we talk about this in the clinic, and what are options for management? So there's kind of 3 big buckets I think about. There's also a procedural bucket, which I'm not going to get into today, but hormonal therapies are often one of the first line options. And you'll notice I say hormonal therapies, not birth control, even though many of these therapies do double as birth control. I think it's important to acknowledge that we don't always use them just to prevent pregnancy. We're using them really to manage the heavy menstrual bleeding. And the goal with these hormonal therapies is that we prevent or reduce the buildup of the endometrium over the menstrual cycle, and subsequently there's less menstrual loss. And actually, some hormonal therapies can get rid of periods altogether, which is really important for patients with certain bleeding disorders. So I think about patients with HHT who have uncontrolled bleeding from abnormal vessels throughout their bodies. They really can't afford to be losing any more blood. So if we can turn off periods in that patient population, that's really the best for everyone. Another option is tranexamic acid. It's also an excellent option. It reduces menstrual losses by a lot. It's very appropriate that we use that for heavy menstrual bleeding, because what it is an agent that slows down fibrinolysis, or the breakdown of clot, which is a super active process in the uterus. So we've seen a lot of good success with tranexamic acid in patients with and without bleeding disorders for the treatment of heavy menstrual bleeding. And then the question often comes up about factor, and I'll show you some data on factor later. That's usually kind of our last option, because it's just a lot more cumbersome and a lot more expensive for patients. And the data actually show that it doesn't really help more than these other options. And of course, neither tranexamic acid or factor have the benefit of potentially also preventing pregnancy. So we like that feature as well. And so, talking a little bit about research. So, in my own research, one of the things that we've been trying to look into is improving our diagnostic tools, because we're seeing a lot more patients coming into clinic preferring the use of the menstrual cup, or maybe the menstrual disc or period underwear. And our diagnostic criteria are really based on pads and tampons. And so, we did a study. We were actually the first people to test the absorption capacity of menstrual products for human blood. Now, it's important to note that we weren't able to use period blood because you just can't collect it in that volume. But we did use packed red blood cells, which are one of the components. If you give a blood donation, it's broken down into multiple components. We used units that were expired, so we didn't take them from anybody who needed them. But we found a pretty broad range and a really impressive degree of absorption in a lot of these products. So pads, the heaviest pads could absorb up to 50 milliliters per cycle, or pardon me, 50 milliliters per pad, like an overnight pad. And when you consider that 80 milliliters per cycle is an objective definition of heavy menstrual bleeding, you can see how someone can very quickly get to that. Tampons in general held a little bit less than the overnight pads, but still often up to 30 milliliters. The brand of period underwear we tested didn't absorb a lot, which maybe other brands are better, but I will note that I don't have a lot of folks in my clinic saying that they use period underwear, but I do have a lot of them saying that they've transitioned to the menstrual cup and occasionally the menstrual disc. And as you can see here, these can hold really large volumes of blood. So this is an important part to incorporate into history taking, and when you as a patient are telling your doctor or healthcare provider about your bleeding, to help us kind of estimate the overall losses. Another kind of research that we're working on right now. So unfortunately, I don't have any data for you because they actually came in shortly after the deadline for these slides. But I will tell you, we are, as a kind of group of menstrual health researchers, looking more and more into the use of menstrual blood for the diagnosis of certain problems, like different causes of heavy menstrual bleeding, for example. And we're already starting to find some very interesting things about differences in the menstrual blood of folks who have versus don't have heavy menstrual bleeding. And the reason that I even mention this without data is because I think it's really important to get the word out about these kind of studies. It took me a really long time to get my research funded, and that's because people didn't believe that I could get participants to bring in their menstrual blood and just tell them, you don't know women. You don't know what women will do to help others and get more information. So these studies are out there. I think we're hopefully seeing more and more, and want to make sure that people are aware of them and that this is a potentially really important tool coming in the next several years to improve our understanding of heavy menstrual bleeding in patients with and without bleeding disorders. Now to some recently completed research that I think it's really important to know about. So this was the VWD MIN study, and I'm sorry, my slides keep inserting this error of doubling the word VWD, but you get the idea. So this was a really very intelligently designed study of patients with both von Willebrand disease and heavy menstrual bleeding. And the question they wanted to get at was whether or not factor would provide improved control of heavy menstrual bleeding compared to tranexamic acid. And so they had patients randomized to either tranexamic acid or recombinant von Willebrand factor, and they tracked their cycles, used a pictorial blood loss assessment chart to measure the severity of their heavy menstrual bleeding for 2 cycles, and then they switched over to whichever one they weren't randomized to up front. And so what you can see here is the red line is tranexamic acid, and the blue line is the recombinant von Willebrand factor. And basically, whatever gets up higher is better in this graph. And so really they were pretty comparable. And if anything, tranexamic acid was maybe a little bit more effective than recombinant von Willebrand factor. That did not statistically come out to be the case. So I want to be clear that I'm not saying that. But when you consider that for factor, we're asking people to, put in an IV and give themselves an IV medication, it's actually really good news that tranexamic acid is as effective as it is. And so this is why tranexamic acid continues to be one of our first line treatments. So the next kind of life event that I want to talk about briefly here is pregnancy and bleeding disorders and things to plan for. And so, I think we all are very familiar with all of the discussion around delivery in infants that could be potentially affected with hemophilia, severe hemophilia. There's a lot of conversation going on about how do we reduce the risk of an intracranial hemorrhage or other kinds of bleeding, and that's absolutely important. However, it's also important that we don't forget about mom, and that happens a lot. And so we need to be having conversations about the impact of cesareans, for example, on mom, when we're thinking about should we go with that mode of delivery because we feel like it might be a little bit safer. And I have some slides on those details later. It's also very important to have a hemostasis plan for the time of delivery. So what is going to happen around epidural placement? What is going to happen at the time of delivery? What's going to happen if there's excessive bleeding during delivery? You want to have all of those plans in place. And then to have a postpartum hemostasis plan. This is, I think, even more neglected. And it's really important because a lot of times during pregnancy, factor levels, specifically von Willebrand factor and factor 8, will get up into the normal range for a non-pregnant person, and they start to drop pretty rapidly after delivery. So we want to make sure that we're sending patients home with the tools to deal with it if they notice increased bleeding, and also making sure that they know to reach out if they notice that increased bleeding as well. So just one slide here on fetal concerns and mode of delivery, because it is really, the first question that comes up. And so why does this matter? So we are thinking specifically about the risk of intracranial hemorrhage in an infant who might have severe hemophilia. And the thing that we really want to avoid is something called an assisted vaginal delivery, meaning a delivery where there's a use of forceps or vacuum. That has up to a 10% rate of intracranial hemorrhage in infants with severe hemophilia. So we really want to avoid that. However, the risk of an intracranial hemorrhage is really pretty comparable between folks who have unassisted vaginal deliveries and folks who have cesarean deliveries. The argument that people do often make for the cesarean is that, well, that's the only way we can guarantee that forceps or vacuum won't be needed. However, I think it's also really important to realize that cesarean delivery is a more morbid procedure for mom, right? It increases antibiotic use, ICU admission, the need for general anesthesia, and recovery time. So it's all, it's a big picture of mom and baby together. We want to make sure that we're taking into consideration both of their needs. So what are important components of a delivery hemostasis plan? What as a clinician should we be talking to our patients about, and what as patients should you be asking your provider about? And so the first thing that I think needs to be discussed in most cases, because it's kind of the hardest to change, is the delivery location, right? So we want to make sure that somebody who needs factor is going to deliver in a place where that factor can be delivered and monitored. And so sometimes that can happen in the hospital that you're already associated with. Sometimes you need to plan to deliver in another hospital. So having that conversation up front is really important. Also, key for delivery planning is knowing what the levels will be at the time of delivery. And so here we're talking about getting usually between 34 and 36 weeks, third trimester labs, looking at peak levels of von Willebrand factor and activity, and factor VIII. And that's really what we use to plan our factor use. And so it's important to know, again, what the plan is for factor. What is the goal that we want to get to? And be taking into consideration the risk for postpartum hemorrhage in that individual patient. So what about the postpartum plan? So things to make sure that we're talking about is the factor plan for after delivery. If we need factor at the time of delivery, I typically continue it a few days after that. So knowing if that's the plan, if there needs to be a plan to administer factor at home, another important consideration. You want to think about monitoring needs, monitoring response to treatment while you're in the hospital with labs. And also something that often happens in my practice is I'll get a patient referred to me while she's already pregnant, and she'll say, well, somebody thought I might have had a bleeding disorder, but they couldn't really diagnose me, or my mom has it and I might have it. And we can't often make or rule out these diagnoses in pregnancy because the levels are increased during pregnancy. So repeating factor levels at 6 weeks postpartum to get new baseline is often an important and neglected part of postpartum hemostasis. Tranexamic acid is super important as well. I make sure all of my patients with bleeding disorders go home with tranexamic acid. They may need to take it in a scheduled fashion, or they may just need to have it available as needed, but it's so much better to have that available at home rather than having to address it after delivery. And also information on when to be worried or to call. And I will say the vast, vast majority of these questions will need to go to the OBs, because the OBs are more experienced in what normal obstetric bleeding is like to make that distinction. And also, just because a patient has a bleeding disorder doesn't mean that they can't get any of the other many reasons for postpartum hemorrhage, like retained products of conception, that need to be dealt with by the OB. So some recent data in pregnancy and bleeding disorder research. So the PRIDE study was recently presented at the American Society of Hematology annual meeting. And they compared patients who got up to 80% levels of factor VIII or factor IX by the time of delivery to those who didn't get to those levels, but who were treated with factor to get them to or above that level. And really, they found that with that correction, those who corrected on their own versus those who needed supplementation had similar rates of bleeding, but it was still higher than in patients without inherited bleeding disorders, which makes us think that 80% probably isn't high enough. There's another active study ongoing right now led by Dr. Jill Johnson out of the Washington Center for Bleeding Disorders, doing something similar for von Willebrand patients, but targeting a higher level. I think she's aiming for about 150%, which is very logical when you consider most patients without bleeding disorders get to 200 or 300% by the time of delivery. So this is a really exciting ongoing study that I'm looking forward to seeing data from. So just a quick couple of last slides on menopause. So menopause, I like to refer to as puberty in reverse, because I think it gives some good perspective. There's hormonal changes, but they're in the opposite directions. And periods often become irregular and may be heavier. So while it's important to know that that can happen, you also want to make sure there's ongoing conversations with a physician to make sure that there doesn't need to be additional workup done. For example, looking for fibroids or looking for malignancy, and if those may be contributing to heavy bleeding. But periods in my patients never seem to go quietly into that good night. It's always a little bit rough on the way out. So when to seek help, so any postmenopausal bleeding, any vaginal bleeding that happens after a year without periods, you need to seek help for. Risk factors to be aware of. So obesity and family history of cancer are both risk factors for uterine cancer. So patients with those need to be followed a little bit extra closely, and there's going to be a lower threshold for doing some investigations. Bleeding with sex is also always abnormal, so something to look into and do some investigation of. And then any bleeding, of course, that interferes with quality of life should be addressed. So this big empty slide is about menopause and inherited bleeding disorder research is because I couldn't find any studies addressing this currently. As one of my friends said yesterday, menopause is having a moment, so hopefully we'll hear more about this in the future. But right now I don't really have anything to share with you on that topic, unfortunately. So my last two slides here are really just about how can we advance research on women's health and bleeding disorders. So participation in clinical trials and donating specimens for clinical trials and studies, very important, very helpful. Tracking symptoms digitally can also often contribute to data. So for example, the Apple Women's Health Study uses tracking data from their apps, which is great. And then sharing your story, just like Connie is doing with us today. It's really helpful for us as researchers to see where the gaps are when we hear what is most pressing and important to our patients. Finding clinical trials for women with bleeding disorders. So just a few resources for you. Actually, the NBDF registry, I apologize. I'm not sure why I had that old term in there, but look into NBDF. They have a research database. Your local hemophilia treatment center should have one. Clinicaltrials.gov, also accessible to doctors and patients alike. And then organizations like the Foundation for Women and Girls with Blood Disorders and HTRS will often have listings of available studies. And finally, advocacy groups are incredibly powerful. Patients share a lot of valuable information with each other, and so that's a great way to connect to research opportunities. And so I think my time is up. I may have gone a little long, my apologies. But you can follow me on X or Blue Sky. I try to do a lot of education there, and I also am part of a educational and anti-period poverty organization known as Dr. Period Hacker. So we have information there as well. So thank you very much for your time.
All right, great. I'll go next. So Leslie's Keith with from the thrombosis side. That was excellent and so important. Thank you so much for that talk. All right, I'll just pull up my slides here. So my focus today is on the other side of the coin and reviewing from a research, evidence base. What's new in venous thromboembolism or blood clotting prevention? And this is a focus on women's health, but I'd just like to acknowledge that terminology of an idea of women plus, really meant to be more inclusive of all genders and represent gender-related roles often associated with caring for young families. So similarly, I'll talk through those, events in a lifetime, hormonal contraceptive therapy, pregnancy, and hormonal replacement therapy, with more of a focus on cisgender individuals, although some information can be similar. And I'll focus more on blood clotting, or known as venous thromboembolism, or VTE. This is a combination of deep vein thrombosis, DVT, in the legs with the potential for blood clot in the lungs, or pulmonary embolism, or PE. So let's start with Julie. This is an 18-year-old meeting with her doctor to review contraceptive options. Her mother, sitting here, had an unprovoked or out of the blue blood clot, and her mother was tested and found to be heterozygous for factor V Leiden gene mutation, a genetic blood clotting condition. Should Julie be tested for factor V Leiden? This is her looking at us. What are safe contraceptive options for her? We finally have updated research. We've been using, I think, the same numbers to talk about risk of VTE with contraception since 2011, 2012, and we have an updated Danish cohort study, updated from the same one with newer data just last month. So I'll highlight some information from there. So just a little bit of a background on contraception, also acknowledging it can be used for other, other indications as well, including treatment of heavy menstrual bleeding, is that progestogens are the backbone of the contraception, or you may hear progesterone. This inhibits ovulation by negative feedback loops with hormones, as well as having a local effect on the uterus and cervix. And this long-term progestogens is a combination of physiologic progesterone, what your body makes, as well as synthetic progestins. And don't get me wrong, estrogen is important. It helps to suppress gonadotropins, prevent follicle development. And one big important piece is reduction of irregular menstrual bleeding or irregular bleeding that can be caused by progestins. And I think something to recognize is that all progestin-only methods will have variable vaginal bleeding after the first few cycles. Some more likely to, stop menstrual bleeding than others, but that estrogen helps to kind of stabilize or settle that irregular bleeding. So what are the players? We have options for combined hormonal contraception, or CHC. This is both estrogen and progestin. Either a pill, a transdermal patch, or a vaginal ring has both estrogen and progestin, or progestin-only options. This is a low-dose pill, intrauterine system IUS or IUD, an injectable DMPA, also known as Depo-Provera as the trade name, or subdermal under the skin implant. And when we talk about blood clotting and systems, our blood clotting system is always in balance. In your body, you have proteins that help make the body make a blood clot and proteins that stop the body from making a blood clot. And what is happening with CHCs, combined hormonal contraceptives, is it tips the balance for changing the blood clotting proteins, where there's more procoagulant or more blood clotting proteins and less anti-blood clotting proteins when we introduce CHCs. And sometimes in people, we also see this with inherited or conditions, thrombophilia or blood clotting tendencies, where they may make more blood clotting proteins or less of the anticoagulant proteins. So important to, think of the balance both from the medication, but also the patient, person's body. Thrombosis Canada and StopTheClot.org are excellent resources about thrombophilia and other information about blood clots. In recent research, we do see that once the CHCs, combined hormonal contraceptives, have stopped, the blood clotting changes mostly normalize by 2 to 4 weeks after stopping, based on surrogate markers of these, of these different proteins. When we talk about risk relating to contraception and other medications, I just want to highlight this concept of relative risk and absolute risk. Relative risk is how much more likely one group of people is to experience a group compared to another. And this is an example, unrelated, but an example. A new drug reduced cancer incidence by 50%. But in absolute terms and absolute risk, when we look at the actual numbers, this would be the same as saying the new drug reduced cancer incidence from 2 per 1,000 to 1 per 1,000. So 2 to 1, reduction by 50%. But it is also important to keep that absolute, risk in mind, and it may not, be as easily reported. So when we look at combined oral contraceptives, so the pill form, the baseline blood clotting risk in somebody not on the medication in someone who's young is 2 to 3 people in 10,000. The relative risk of a combined oral contraceptive is 3.5-fold higher, 3.5 times higher kind of the equivalent of that 50% example. But in absolute terms, that number is still overall low. It is increased, but still around 5 to 15 people in 10,000, or less, far less than 1%. There are certain risk factors depending on the type of pill, the higher estrogen dose, later progestin generations, and shorter use. Someone is more likely to have a blood clot if they had just started versus somebody who's on it for longer, although the risk does still persist. From the recent research, we have information that thrombotic or blood clotting risk is associated with the pill, the transdermal patch, the vaginal ring, as well as the progestin-only DMPA. And this most recent study also identified a small possible increased risk with the subdermal implant. I'm bringing this up because we have overall less data, but we do have information now that it does slightly increase the risk. In absolute terms, this is from the research study, 3.4 people in 10,000. So overall, big picture lower. From the research studies, there's no blood clotting risk and meta-analysis or combinations of research studies also show this with the IUS or IUD and the low dose progesterone-only pill. With some caveats is that there was a small increased risk in this last paper, although many others not having the risk. We have a new product on the market, SLIND, or the drospirenone, which is a slightly higher progestin risk type, but so far what we have is reassuring. And if higher doses of progestin are used to treat bleeding, that does carry a small but important thrombotic risk compared to a low dose low dose more used for contraception. So whenever we have these important discussions, it really is individualized and patient-centered care with the patient in the middle, ideally, but it can be challenging, surrounded by different healthcare team members, your primary care provider, gynecologist, and hematologist or blood clotting specialist, because we may not have all the answers. My focus is on that VTE risk, patient and specific agent, but there's many other considerations: mode, duration, cost, indications, benefits, risks of alternatives. And I may have my information about VTE risk, but knowing and big picture that it may not be about the VTE risk for these discussions. It may be about heavy menstrual bleeding as the focus, avoiding unwanted pregnancy, and many other indications which may be more important than that VTE risk. I'll put this controversial statement up: thrombophilia and CHC, a condition that represents an unacceptable health risk if the contraception method is used. This is the latest statement of the medical eligibility criteria for contraceptive use in the US from last year. And just to acknowledge, this is a very black and white statement. But when I have a patient in front of me thinking of the puzzle pieces or that triangle, really it's our this gray zone where there's more factors than just that blood clotting risk. And an example is that for people who have low risk thrombophilia or blood clotting tendencies that are more mild, the risk is there, but it is much lower than somebody with a high risk thrombophilia, where we would likely avoid the combined hormonal contraception. So it is really individualized. This also goes along with the recent 2023 ASH thrombophilia guidelines for women with a family history of VTE and unknown. The family member doesn't know their status of thrombophilia. The ASH guideline panel suggests not testing for hereditary thrombophilia to guide use of the combined oral contraceptive. For women with a family history of VT with known factor V Leiden or prothrombin gene mutation in the family, similar to our patient Julie, the guidelines suggest not testing for the known, thrombophilia. But if there's a family history and stronger thrombophilia, the ASH guideline panel does suggest testing and if positive, to avoid use. There's a lot of also wording about patient values and preferences in the thrombophilia guidelines, and these are only suggestions. We do have information from research studies for people who have added risk factors of blood clotting, including thrombophilia or past blood clots. And what we know is the progesterone-only IUD or pill shows no added blood clotting risk. We do have a signal for blood clots for that DMPA progesterone-only injection, and we don't have separate data for the subdermal implant. Some additional counseling information that I always share, information for patients and their doctors is having a family history of blood clotting, regardless of thrombophilia status, does still increase the risk of thrombosis by 2 to 4-fold. Big picture, these numbers are still very low, but a family history, or those with a mild family history with the mild thrombophilia, that just may be enough to avoid CHCs in those with a low tolerable risk and other acceptable options like a progestin-only IUD. But if it's chosen, then also to consider the agent with a lower estrogen dose and a second-generation progestin is recommended. All right, so here is Julie now coming to your office or coming to the office to talk more about pregnancy planning. She did not get tested for factor V Leiden and wanted, regardless, it wouldn't have changed what she did because she did want to avoid that added thrombosis risk and use a progestin-only IUS or IUD. She's now wanting to become pregnant and is wondering if she should receive injectable blood thinners during or after delivery. If she had factor V Leiden, should she be tested now? We know that pregnancy is associated with a 5 to 10-fold increased thrombosis risk, around 1.2 in 1,000 deliveries. The risk is similar, split up between the antepartum or during pregnancy and postpartum time, but that 6 to 12-week postpartum period is shorter, so there is a higher daily blood clotting risk. We often add, those injectable blood thinners on postpartum sometimes and not during pregnancy for that reason. And just to acknowledge that the symptoms of pregnancy and VTE overlap. We see a higher heart rate, gradual shortness of breath can be very common in pregnancy, as well as gradual leg swelling. And often it's those, sudden changes, all of a sudden worsening shortness of breath or leg swelling or pain one side or more than the other, that could be clues, but it can be challenging. So who should receive those blood thinner preventative injections? From the ASH, American Society of Hematology guidelines, both during pregnancy and 6 weeks after pregnancy, anybody who's had a past unprovoked out of the blue blood clot or an estrogen related blood clot should receive the low molecular heparin injections. There's some controversy on the dose postpartum, whether it should be preventative or slightly higher dose, but should be offered. For those with a past provoked blood clot from a major provoking factor, the blood clotting risk during pregnancy is lower, and so the recommendation is clinical awareness, ongoing reassessment during pregnancy, and giving the injections after delivery. Those with the strong thrombophilia during pregnancy and after delivery, and the mild thrombophilias, it's a big mix based on minimal information and data. Some guidelines suggest it, others don't. What I have here is the ASH guidelines, but it is more of a discussion and just ongoing monitoring for symptoms. Updated research in this area is recently published, the pilot partum trial, which is a pilot or test run to see if a trial of giving low-dose aspirin for 6 weeks versus a placebo pill, is it feasible to make a much larger trial possible to give us the answer if a low-dose aspirin could prevent blood clotting, compared to what we do now, which is a bit of a mix and may include those low molecular weight heparin injections. We included and enrolled 257 patients across 4 countries. And overall, we found that it was feasible. Low-dose aspirin was safe and acceptable to patients. But the major challenge we came across was the comfort, that unknown risk with the placebo group. And so we have revamped, in our full PARTM trial design is low-dose aspirin versus usual cares, or what is standard practice at the site with low molecular heparin injections. So this full PARTM trial is coming soon. And I very much, if anyone is interested from a patient partner perspective, I am looking for future patient partner input on some of this information. For those with mild blood clotting tendencies or 2 or more risk factors, people who've had past blood clotting or the stronger thrombophilias should be on the low molecular weight heparin. All right, so now Susan, who's Julie's mother, wants to talk. She's had a prior unprovoked blood clot and wants to know if it's safe to be on hormone therapy for menopause. This picture is AI generated, and the poster does keep changing in the pictures. They're getting a little funnier. So unfortunately, it's very similar to the bleeding disorder arena as well. We have no new data in this area. What we do know is that if she remains on anticoagulation or blood thinners, she can be on hormonal therapy. This is extrapolated from combined hormonal contraceptive data from the Einstein trials, looking at rivaroxaban. If she's not on blood thinners, more of a discussion about the available information and indication for HRT is needed. For those who've had prior blood clots not on blood thinners, we have randomized, or flip of a coin, randomized trial of 140 people, half who received oral or pill form of hormone replacement therapy, half received placebo. The study was stopped early for safety. Too many people, a little over 10%, had new blood clots in the hormone replacement group. This is people with prior blood clots who were not on blood thinners. We also have a cohort study of tracking patients over time, just over 1,000 patients with prior thrombosis without blood thinner therapy. 130 of them used HRT. Those who had the pill form of hormone replacement therapy had a higher risk of blood clotting recurrence. So based on available information as well as other studies not shown here, I suggest not using the oral hormone replacement therapy if you've had a prior blood clot and you're not on blood thinners. What's a bit more uncertain, and maybe promising is in that same cohort study, those who received transdermal estrogen, estradiol, did not appear to have a higher blood clotting risk. It requires discussion because it's one study, the population study numbers were low, there's some uncertainty in the data, and it really is that discussion depending on blood clot history, patient values and preferences, and that joint decision. And the progestogen type also matters in this factor, so more of a discussion to have. So with that, I will stop and turn it over for questions or our next part of the presentation. Thank you.
Super. Thank you very much. I think I'd really like to thank Dr. Skeeth and Dr. Samuelson-Bano for these really compelling presentations, and Connie for being here and really giving us that context that it helps us to really make that connection between the research and people's lives. And I just want to give Connie a moment. Is there anything you want to say sort of to follow up on these 2 presentations before we get into our live Q&A?
Absolutely. I'm just honored to be here today as a living experienced expert and a global patient advocate to hear what was shared. But I just would like to say a few things regarding my story, because it wasn't until I was in my mid-30s that I was diagnosed with a bleeding disorder after a car accident. However, for years, my mother and myself had tried to go and get help from clinical staff so that I could get properly treated and diagnosed, but that never occurred because they never heard me or heard her and what we were sharing. So there was a big issue with being a woman, being from the South, that gender bias, it was, it was there. Generational trauma from my mother's generation, her being an African-American woman living in the South, and not wanting to have the stereotype or the stigma or taboos associated with having herself or a daughter with bleeding disorders. So all of that played into that. And I think it's so important that I share all of that with you, because all of these complexities just add to life with a bleeding disorder and living with a bleeding disorder. And I don't believe I'm alone in this. It takes about 16 years for a woman or a teen girl with a bleeding disorder to be diagnosed. Well, it took me to 35, double that time. But I think all of these complex care needs should be considered, and social needs, because all of this impacts life and living with a bleeding disorder. Not to mention the systemic racism, redlining, and just general overall healthcare disparities that exist for so many people of color. So please, as healthcare practitioners, keep that in mind. And even people that work in community health, always think of the bigger picture of what may be affecting your patients. Because I know as a person living with a bleeding disorder, it certainly affected my life greatly. From being a teen who didn't do as much sleepovers and participating in activities, and always having to have an extra change of clothes and always soiling my garments. All of this came from living with a bleeding disorder and having that experience and not having the proper management and treatment and correct diagnosis that I so desperately needed at that time. And then moving on to becoming a childbearing woman who almost died, having 2 children by emergency C-section. Here again, not having the proper health care that I needed. So all of these factors play in to care with a person with a bleeding disorder. And please be thinking about this. Thank you so much for this wonderful presentation that I'm honored and blessed to be a part of today.
Thank you, Connie. Thank you so much. I think it's always so fantastic to have your perspective, because you really bring it home. You really bring it to people's lives. Just before we start the live Q&A, I want to draw our audience attention to the chat. There should be a chat icon at the bottom of your screen. And if you click on it, you should see a couple of things that I've dropped in there while our speakers have been presenting. There's a couple of links to some resources around bleeding disorders and also around thrombosis, and they're really relevant to what we've been talking about today. So really encourage you to go and have a look and save those for future reference. And I'm just going to drop one more link in there now. And one thing we wanted to mention was that there is that the Hemophilia of Michigan, HFM, hosts a National Women with Bleeding Disorders Conference in October. And registration for that will go live in July, mid-July. And so their website will be updated with that opportunity. So I've put that website also into the chat now. So you may want to go and save that and check in with this chance to attend that important event. And there is also a recent HFM publication related to this. It's an overview of their program. And so we'll email that to all of the attendees for this webinar. So take a look at the chat, grab those links, save them somewhere. You're going to want to go back to them once we go offline. So now we'll turn over now to our live Q&A. And I have a couple of questions I'd like to put to you if I can. So one question that I've been curious about for a while, because I've heard about this: can someone get diagnosed with a bleeding disorder in menopause? Is it possible that they've gone through life without being diagnosed, and it's at menopause that they finally get diagnosed through menopause symptoms? Does that happen?
Yeah, I mean, so I would say people have their diagnosis delayed until they're in the menopausal period all the time. Yes. I have plenty of patients in their 40s and 50s who are like, "Where were you 20 years ago?" And I'm like, "I'm sorry, I wasn't there." So yeah, that happens. I mean, it's not uncommon for periods to get even worse in menopause. So it certainly is possible that would finally drive somebody to come in. It's exceeded their coping skills. But as Connie pointed out, there is a long delay. So 16 years from first symptom to diagnosis is like the average, which means like half of people take longer, right? So it's really sad.
Yeah. So I guess one of the really big challenges is how to measure menstrual blood volume. And I know you talked about, some of the things that have, and I know there are some fairly old methods of kind of mashing up pads and getting the blood out and measuring volume and what have you, and not necessarily terribly appealing. But I was impressed to hear what you said, that people are willing to do this. They're willing to bring their pads in, and I think that's a really important consideration, that people want to contribute to research. But do you have any thoughts on how we can standardize in clinical trials the measurement of menstrual blood volume, also considering that how we deal with our periods is changing? People are not necessarily just using tampons and pads anymore.
I love this question, and I literally just recorded another 20-minute talk on this topic yesterday, so I'll try to take less than 20 minutes. There are a variety of ways of things to do this. The method you referred to, the alkaline hemoton method, it's old, it's expensive, we don't do it anymore. There are like standardized forms, so like the pictorial blood loss assessment chart, which is the one that was the metric used in the VWD Min study I referred to. I think that's the most common. There's another one called the MBQ, or the menstrual bleeding questionnaire, which doesn't have like a precise cutoff for HMB, but does get into quality of life issues. And, I think weighing pads and tampons is something that can be done. We've done that. But also people who use menstrual cups, right? You can just like decant those into like a sealed container, and could potentially collect it volumetrically that way. So we do have a lot of tools. Basically, anything is better than what we've been doing up until now into the anticoagulation studies, where they're just like, oh, if you have a face-to-face interaction with a doctor where you mentioned heavy menstrual bleeding, we might give you points for it, but how many women are suffering without coming in and seeing a doctor? So anything is better than what we're doing.
One question that we received was, somebody was saying that women and girls who are being treated for a bleeding disorder, they may experience an unexpected blood clot for various reasons. And can you talk a bit about how specialists work together to prevent clotting when there is treatment for a bleeding disorder, and then also to care for them if a clot does occur?
Maybe I'll go first, but it may be good to hear from both of our perspectives. Often in many locations, a hematologist may cover both thrombosis and bleeding. But if not, I think that really, key back and forth and having a discussion is really key. For example, that medication tranexamic acid, we have some data that is reassuring to use with past history of blood clotting. And so it is that shared decision, and often, or ideally, it is a similar same person. I don't know, Dr. Samuelson Beno, what you think.
So I do both bleeding and clotting. I will say this has actually come up for me more with somebody with like atrial fibrillation or a non-thrombosis indication for anticoagulation. And yeah, it exactly is. It's a back and forth conversation, right? And how can we minimize the risks on both sides? So can we use a Mirena IUD to stop periods so somebody who's having to take anticoagulation is at least not having to deal with that kind of bleeding? Can we go to a lower dose anticoagulant down the line after 6 months if that's appropriate? Or do we need to, and we do sometimes do this, sometimes we have to give factor to kind of like normalize the coagulation so we can give the anticoagulation, which sounds a little bit backwards and probably is, but because we don't have a reliable way to like measure whether we're rebalancing things or not, we tend to just do what we know.
But I want to say, I think what was really important with what both of them just said is it's the back and forth. It's the listening to your patient partners.
Well, and speaking of patient partners, I do want to just get this in under the wire. Dr. Skeeth mentioned an interest engaging with patient partners in some of the work that you were doing. Did you want to let our audience know how they could get in touch with you if they are a patient partner who might be willing to partner with you on this?
Maybe if the MBDF has a contact or information, then I'd be happy to share my email or resources about the Partum trial. We also have a website, partumtrial.ca, with a contact us button. But happy to connect if there is a patient partner who would like to learn more about this study.
What was the website that you said?
It's partumtrial.ca, and there is a contact us button.
So
There,
partum, like postpartum, partum trial?
at partumtrial.ca.
Yeah.
And there's a contact us or through this organization. Happy to be connected behind the scenes as well. That
Okay,
yeah,
perfect.
perfect.
And I think I just had a note that also people can contact an NBDF email address. Just trying to scroll to the right spot on my screen for that. I think it was research@bleeding.org. So if you want to write to research@bleeding.org, I put that into the chat as well. You can get in touch with Dr. Skeeth via that address. We've just had another question come in. I'm just going to have a quick look at that because I know we're close to time, but I really do want to give you the chance to respond to the questions that have come live from our audience. So if you have one moment more, I will ask you one more question. This has come from an attendee, and they're thanking you for this excellent discussion and asking, how do you counsel and manage women with a significant bleeding history or heavy menstrual bleeding who do not meet criteria for a specific bleeding disorder, like mild VWF deficiency, for example, or a mild factor deficiency, that's not expected to cause clinically significant bleeding or bruising?
That's a great question. So I would say the fortunate thing is that we treat heavy menstrual bleeding pretty similarly, regardless of the underlying cause. I hope someday we have more specific treatments, but the management is typically the same, right? We use tranexamic acid regardless, and hormonal therapies can be beneficial as well. You know, we are becoming, I think, a little bit better at listening to our patients, Connie. We're working on it. And now the most commonly diagnosed bleeding disorder is actually bleeding disorder of unknown cause. And I make that diagnosis a lot when somebody comes into my clinic and they have heavy menstrual bleeding, and maybe they have had bleeding after dental work or something else. There's heavy menstrual bleeding plus something else. I've sent all the labs. Basically, from my perspective, the purpose of the labs is to rule out anything that we have specific replacement for, not to say whether or not you bleed. It's your history that says whether or not you bleed. So if I rule out everything that I can specifically replace, then we fall back on tranexamic acid, which is actually very effective. So hopefully we're getting better at paying more attention and giving that diagnosis more often.
That's super. That's a wonderful progression from you can't have a bleeding disorder because you're a woman. I know people have heard that, and I'm so glad to hear that that is going the way of the dinosaurs.
Yeah.
Well, thank you so much. I think we're going to have to wrap up our Q&A now. I really want to thank Connie Montgomery, Dr. Samuelson-Bano, and Dr. Skeeth for sharing your time and your expertise with us this afternoon. And I'd like to thank everybody in our audience for joining us as well. This recorded webinar will be available shortly after it ends on bleeding.org under the events tab. And if you select past events, you can find all our archived webinars there. And please mark your calendars now for the next Research Journal Club. On Wednesday, July 16th, Dr. Shannon Carpenter and Dr. Lauren Amos from Children's Mercy Hospital in Kansas City will tell us all about research in children and adolescents with inheritable bleeding disorders. So please join us for that. Thank you so much for joining us.